My name is David Neal. I'm an orthopedic surgeon here at Orthopedic Associates of Flower Mound and Northlake. And I wanted to tell you a little bit today about hip replacement, and in particular the direct anterior approach. So ultimately, hip replacement is an operation for individuals with hip arthritis that's causing debilitating pain and hurting their quality of life. And a hip replacement, regardless of the approach, is an excellent operation for improving pain, function, and quality of life. There's multiple possible approaches, and the approach that I utilize most commonly is the direct anterior approach, where the incision is made on the front of the hip and you go between muscles on the front of the hip, as opposed to other approaches which involve going between muscles on the side or posteriorly on the back of the hip to perform the hip replacement. Well, this here is an x-ray of a right hip for a patient who's been having pain in their hip and groin region for many years. It's been getting worse despite conservative treatment measures. You can see the hip is a ball and a socket joint. You can see the ball and the socket there. And some things that you can see that demonstrate arthritis is that the space between the ball and the socket is narrowed. That's the space where the cartilage is, and that's really what arthritis is. It's the progressive wearing away of that protective cartilage layer, leaving exposed bone underneath. That bone has nerves in it. The way I tell patients to think about it is almost like having a toothache, but in the hip. That's severe arthritis that has failed conservative treatment like medications, therapy, exercises, injections, makes this patient a candidate for a total hip replacement. Some unique aspects of a direct anterior hip approach, going through the front of the hip as opposed to the back, is there is potentially a lower dislocation rate because you don't have to cut the tissues in the back of the hip and wait for those to heal. And most commonly, if a hip is going to dislocate, it is usually posteriorly. And so by preserving those tissues, you do have a lower dislocation risk. Another benefit is, theoretically, there is a faster recovery in the first 6 to 12 weeks, just because you do not have to violate the gluteus maximus muscle. So that muscle is not cut or disturbed when performing the surgery through a direct anterior approach, allowing for a quicker recovery for patients.
The biggest difference to me, I guess first and foremost between the approaches, was the initial restrictions placed upon a patient when they have either a lateral or a posterior approach. The inability to cross your legs. So for example, you had to sleep, be careful during sleeping in the position that you chose to sleep in so that your legs did not cross center line on the operative leg. You could not bend 90 degrees either way, up or down on the operative leg. Those restrictions remained in place for 90 days. That certainly was not an issue with the direct anterior approach because those restrictions were not put in place. The second, and probably from my perspective anyway, the most critical benefit, or the biggest benefit from my perspective of the direct anterior approach, was the rehabilitative process and the fact that it was, in my opinion, I don't know if it's the correct word, but muscle sparing. And so I had lost no strength in my glutes or the ability to squat, stand up, or be able to hold my leg in place, relative to center line. That recovery period was dramatically quicker than the posterior approach. I had much greater strength, and I was able to return to physical activity much quicker on the second surgery relative